you through tips and tricks on total knee arthroplasty, and I'm going to try to keep this as practical and clinically relevant as possible. So by way of disclosures, I do have a product development agreement with Corin on their Omnibot platform, but that won't be relevant for today's discussion. So the goal of this talk really is to provide you with tips on ways to stay out of trouble. As Warren Buffett said, it's much easier to stay out of trouble now than to get out of it later. So I could provide you some thoughts on all of the aspects of the perioperative pathway, but I'm going to focus my comments specifically on the pre-op and intra-op considerations. And if there's time left during Q&A, I'm happy to share my thoughts on the post-op pathway. So starting with the preoperative evaluation of the patient with knee arthritis. One of the first things to assess during the clinical exam is the coronal deformity of the patient and to determine if it is correctable to neutral. If it's not, then you should be prepared to do more soft tissue releases to balance the knee. Additionally, you should examine the collateral ligament competency at 0 and 30 degrees. And if there's significant laxity, anticipate the need for a higher level of constraint at the time of surgery. In the sagittal plane, a fixed flexion contracture should key you in to being prepared to make a larger distal femoral resection, as well as the need to remove posterior osteophytes and perform an aggressive posterior capsular release. Conversely, with the recurvatum, one has to be mindful of the extension gap and be conservative with that initial distal femoral resection. And in cases of polio plus recurvatum, a primary hinge knee replacement should be considered. While quad weakness is probably the most common cause of extensor lag, the etiologies are multiple, and the reasons should be further worked up before entertaining surgery. Regarding stiffness, I think it's important to counsel patients that the best predictor of post-op range of motion is the motion they enter surgery with, so that the goals and expectations of patient and physician are reasonably aligned. As for incisions, I always tell patients that they're going to experience numbness on the lateral aspect, given the sensory innervation to the anterior skin. While it's important to respect the more tenuous vascular supply to the knee's overlying skin, most incisions can be incorporated or avoided. Transverse incisions can be crossed perpendicularly, and when multiple longitudinal incisions exist on the knee, the lateral one is the safest to use. So now moving on to some red flags you may see on the x-rays of your clinic patients. Obviously, these knee x-rays don't indicate isolated unicompartmental lateral knee arthritis, but rather degrees of MCL incompetence. And the question is really, what level of constraint will be necessary at the time of the total knee replacement? For this one, we could get by probably with a semi-constrained implant and note the cemented stems to buffer or bolster the fixation. Whereas this one, not surprisingly, required a primary hinge total knee replacement. Scrutinizing the lateral x-ray for patella baja, especially in cases where patients have evidence of prior BTB, ACL reconstructions, HTOs, or other periarticular knee surgeries is important, as I know this will be a more difficult surgical exposure and may adversely affect patella tracking. In these cases, I take my time removing the infrapatellar scar tissue right after the arthrotomy. At times, I perform my patellar resection right off the bat, and I'm very mindful not to raise the joint line, which can exacerbate the problem. While it's not uncommon to see some patellar tilt or subluxation in a valgus deformity, when I see it in a varus knee, it likely indicates inherent lateral retinacular tightness, which makes me more inclined to perform a release at the conclusion of the case, as long as I've done everything up to that point to optimize the Q angle, specifically avoiding internal rotation of the components, lateralizing my femoral component, and medializing my patellar button. With a very thin patella, as pictured here, you have to make the decision about whether to resurface or not. Most consider 12 millimeters the lower border of safe remnant bone so as to avoid a patella fracture. One option in this situation would be to do a trabecular metal convex patella. Alternatively, you could perform a patelloplasty in these cases as long as the postoperative tracking is reasonable. For bony malunions of the femur or tibia, you have to decide whether it will be possible to correct the alignment through the joint or whether a corrective osteotomy will be needed, either as a staged procedure or at the time of the total knee replacement. My general rule of thumb is to draw out my proximal tibial and distal femoral resection osteotomies on the scanogram. And if the line violates either the origin or the insertion of the collateral ligaments, then an osteotomy is needed, which fortunately happens to be very rare. With retained hardware, it's important to determine whether you need to remove it at all, and if so, how much. Often, only certain elements of the construct will truly get in the way of your arthroplasty prosthesis. But you also need to be ready to use alternate strategies to the femoral intramedullary cutting guide and recognize the implications on ligamentous stability from these prior injuries and surgeries. With patients with ghost bone like this, I would say that cemented knee arthroplasty is the best mode of fixation, and consideration should be given to adding short cemented stems. During these operations, I'm especially vigilant with the resident's handling of retractors, saws, impactors, and even pulse lavage, as I've seen pressurized saline damage the bone in these very osteoporotic patients. Seeing a knee x-ray like this is pathognomonic for Charcot arthropathy and should be approached with extreme caution. It's important to confirm that these patients don't have uncontrolled diabetes, an unrecognized myelopathic spine, and if you're brave and or crazy enough to do this total knee, this is an indication for a primary hinge. So now I'm going to move on to some intraoperative pearls. As mentioned earlier, you want to use the most lateral prior vertical incision because of the medial based blood supply to the anterior skin. While the textbooks often suggest a 5 to 6 centimeter skin bridge, this may not always be possible. That being said, attempts should be made to avoid acute angles between incisions. And after the skin incision, full thickness flaps should be elevated. My residents all know one of my mantras is no fat left behind. And this is to avoid disrupting the rich network of anastomoses in the subcutaneous fat. My surgical workflow is femur first. The entry point to the opening drill is classically described as just anterior to the PCL origin, but I will often modify that slightly based on the scanogram and where the anatomic axis line exits the distal femur. It's important to then over drill or expand the initial pilot hole, shown here in green. One, it ensures the IM guide is truly referencing the endosteal canal and not being misdirected by a tight opening hole. It then allows me to also irrigate and evacuate some bone marrow to avoid causing a storm of fat emboli when the IM rod is placed in the canal. In most cases, the guide is set between 5 to 7 degrees of valgus, which can be personalized for the patient if you get pre-op scanograms, though clinically there hasn't been shown to be any clinical benefit to this approach. It's very important at this stage to place Homans or Z retractors between the femur and the collateral ligaments to avoid iatrogenic injury. I teach my residents to always start cutting the less sclerotic side first to avoid skiving and creating a non-flat surface. And in general, before I actually make this distal femoral cut, I place an angel wing through the slot, ensuring it exits right at the sulcus indicated by the diagram above for an appropriate resection depth. Based on the degree of a flexion contracture present, one can consider cutting extra distal femur, recognizing that raising the joint line can create mid-flexion instability and patellar issues. In cases where an IM guide isn't feasible, such as femoral hardware or malunions as alluded to before, multiple technologic solutions currently exist. A handheld accelerometer is shown here. You have the option of custom cutting blocks, traditional pin array navigation, and more popularly now, robots, and for historical purpose, extramedullary alignment. I use a traditional measured resection technique, and therefore I have my trainees draw out Whiteside's line and the TEA before putting on the femoral rotation and sizing guide. Given that these lines should be perpendicular to one another, if the TE line they draw appears internally rotated, I just make sure that the rotation guide is externally rotated to their reference mark before pinning it. In bad knees with bad valgus knees with lateral condylar hyperplasia, the drawing of the axes is all the more important to me, as the standard 3 degrees of external rotation from the posterior condylar axis may still leave the patient in some degree of internal rotation. When sizing the femur, always reference the anterolateral femur. Ensure there's no interposed synovium, giving a false measurement. If you're in between sizes, start with the larger one, as you can always downsize and cut more bone. You can't give it back. It's also important to note how your TK system grows between sizes. The one I use grows 3 millimeters between sizes. Therefore, if I've cut the larger size and I'm concerned about some medial lateral overhang, if I estimate that I can get away with another 3 millimeters of resection, I will cut for the size down. Having made the cut, inspect the bone. This grand piano sign is a proxy for appropriate femoral rotation as the anterolateral bone sits higher. If, on the other hand, you end up with an anterior bone resection that looks more like a symmetric hill, you've likely internally rotated your cut. Conversely, if you've overly externally rotated your guide, you will see a very exaggerated grand piano sign. To prevent notching, start your cut anteromedially, as it isn't as deep a cut, and you can anticipate what will ultimately happen anterolaterally. Also, if you are notching, just stop short where you anticipate the proximal aspect of the femoral component will sit. You don't want to keep blindly plunging further up the femur and make things worse. You can always use a burr runger to smooth out the notch for better aesthetics on your postoperative x-rays. And if you notch, it isn't the end of the world. I've notched many femurs in my day, and I've taken care of a number of periprosthetic distal femur fractures, and I haven't seen that association once. For the proximal tibia cut, my classic teaching is measure thrice, cut once. And what I mean by that is you have to first check your coronal and sagittal alignment of the cutting block and your depth of resection before pinning it. Once you've made the cut, then it's important that you do the double check of not only inspecting your bony resection wafer, but also using a drop rod to check alignment. To set the coronal alignment of the tibia, You want to first draw an AP axis right down the tibial spines. And the reason is that you don't want to create a varus or valgus resection by the slope that is cut into your proximal tibia. Then I palpate the distal tibia and ensure that the shadow created by my headlight and the vertical bar of the extramedullary guide are collinear. For the sagittal alignment, my first step is to look at the lateral X-ray hanging in the room to assess the patient's native slope. Then you have to determine the goal for your TKA, which will differ if you retain or resect your PCL. With CR knees, it's recommended to cut some slope to assist with femoral rollback, while PS knees aim for neutral slope to avoid increasing the flexion gap. I caution people who use the 3-2 finger technique under the bar to assess slope, because the body habitus can really throw off the accuracy of this assessment. I prefer to eyeball the relationship of the lateral plateau to the cutting guide, or actually swoosh it. Regarding the depth of resection using the 2-9 stylus, for regular varus knees, I will reference 9 millimeters off the unaffected lateral side to ensure I have enough space for the smallest composite tibial component with poly. For standard valgus knees, I will often float the 9 millimeter finger off the less affected medial side, as any more than that, you'll be chasing the gaps for the remainder of the case and likely end up with a very thick poly. In severe deformities, I will consider cutting 2 millimeters off the affected side, but more often than not, I'll often stop short of cutting to the bottom of the deformity to avoid removing too much bone on the less affected side. This unresurfaced bone can be addressed by burring the sclerotic bone or using a screw and rebar technique if needed. So after measuring thrice and cutting once, then I'll do the double check, which consists of looking at the resected bone from the front and the side and confirming that it's consistent with my preoperative plan. Then you can use a drop rod to see you've achieved your coronal and sagittal goals. If you've inadvertently cut the tibia and varus, the drop rod will head towards the lateral malleolus. And conversely, if you've cut it in valgus, the drop rod heads medially. This can be corroborated by the bone wafer you removed and identifying a deeper cut on the medial or lateral side respectively than what you planned. Next, you can check your flexion extension gaps with one of these spacer blocks, with the goal of obtaining symmetric rectangular gaps that accommodate at least the smallest composite thickness of your system. While our goal is a rectangular gap, what if you get a trapezoidal gap? What does that imply? Well, I simply put, I think of it in terms of bony issues, either the femur or the tibia, or soft tissue issues, whether due to the patient's preoperative deformity or an iatrogenic injury. So let's take an example of a trapezoidal flexion gap with a larger medial gap than the lateral one. So if you think about the femur, did you overly externally rotate it and see that exaggerated grand piano sign? Did you cut the tibia and varus? And do you see that the drop rod fell laterally? In terms of preoperative deformity, was this a valgus knee and something we might expect to see? If it was a varus knee and you saw this asymmetric flexion gap, then potentially the anterior MCL has been disrupted. The same line of thinking can be applied to a trapezoidal flexion gap with the lateral side larger than the medial. Was the femur cut in internal rotation and I saw that symmetric hill of an anterior femoral cut? Was the tibia cut in valgus and I noticed too thick of a lateral resection on my bone wafer? Was a patient a severe varus knee and this is part of their underlying pathology? Or did I inadvertently cut the popliteus during the procedure? Most of us are probably using a periarticular injection these days as part of our multimodal pain protocol. We use the Deluri or REC cocktail, which consists of ropivacaine, epinephrine, clonidine, and ketorolac that the pharmacist premix for us into a 100 cc solution. It's important to inject the periosteum because of that rich innervation. And while it makes sense to inject the posterior capsule because the adductor single shot covers most of the anterior knee, we at UCSF have definitely had some transient nerve palsies from spread of the injection to the tibial or peroneal nerve. While these will routinely resolve within 24 hours, it does somewhat delay therapy on the day of surgery. And while some of my partners inject throughout the procedure, I usually take advantage of the downtime when the cement is curing. Regarding patella resurfacing, the goal is to restore the composite thickness of the patella. So if I initially measure the host bone to be 24 millimeters with a caliper, and I know my button is 9 millimeters thick, then I'm shooting for a 15 millimeter residual patella. And whether you use a guide or a freehand technique, the goal is a symmetric resection. And this can be confirmed when clamping the trowel to see if the surfaces of the patella, the button, and the clamp squeezer are all parallel. When sizing the patella, you want to use the largest one that fits the bone without overhanging. And for patellar tracking, it's ideal to medialize it. This may leave some exposed lateral facet, which I will routinely remove with a burr and rongeur, as this exposed bone, if it impinges on the femoral component, can be a source of postoperative pain. If the patella tracks laterally after all your components are in, double check your component position and rotation. Check your pre-op x-rays for a pre-existing tilt or subluxation. Drop the tourniquet and check again. And if it's mild, place a towel clip on the arthrotomy and check once more to see if that corrects it. While lateral release is a powerful technique to help centralize the tracking, I found that patients don't like the postoperative bulge they see laterally on their knee. And I've got a good number of patients with some patellar tilt on their follow-up x-rays who are super happy with great range of motion. And therefore, it's extremely rare for me to perform a lateral release in the primary setting. Few words on cementing. You want clean, dry, bony surfaces. And if you hadn't inflated the tourniquet yet, this is the time to do so. You want to finger pressurize the cement into the bone and blot away all fat and blood from the cement. Then coat your implants, as this will improve the cement implant bond. Make sure to place a little on the posterior condyles of the femoral component, as this will obviate the need to put any on the bony posterior femoral condyles, which would potentially result in excess cement extruding in the back of the knee. Closure should be meticulous and multi-layered. I tend to use a combination of interrupted and running barbed suture for the arthrotomy. For aesthetic reasons and to avoid an extra visit to the office for suture or staple removal, I've moved to a subcuticular closure, which has been a game changer. And it's important to remember to place the dressing on in hyperflexion with very little tension placed on the steri-strips or tegaderms to avoid blistering. Thank you very much.
Eric, that was an awesome tour of pretty much everything that I do in total joint arthroplasty, especially about the knee right now.